Nick's virtual EMS classroom. Today I'm going to be going over part 4 of my 12-lead EKG series. Today we're going to talk about areas of MI and ACS treatment. And more specifically with the areas of MI, we're going to go over certain 12 leads and the areas of the left ventricle and mention some things with the right ventricular areas as well. So the first one I want to mention here is going to be an inferior MI. So patients with inferior MI may present with epigastric discomfort and excessive belching, even heartburn, things like that. If you've been in my classroom before, when we've been in lab and we've discussed MI, I've often said that there's been a lot of people, especially stubborn middle-aged men, that have actually died from they thought was heartburn or acid reflux, when in reality it was actually a big MI. So you will notice ST elevation in leads 2, 3, AVF, which are your contiguous leads for your inferior MI, and then your reciprocal leads are 1 and AVL. So if I see ST elevation in leads 2, 3, and AVF, I certainly want to look in leads 1 and AVL to see ST depression. With the inferior MI, this is indicative of possible right coronary issues. The right coronary supplies the inferior portion, also the right ventricle as well. 50% of the inferior MIs are associated with right ventricular myocardial infarction, and 50% are associated with posterior MI. Now, what we can do is if we notice inferior MI, then we want to go ahead and get a right-sided ECG so that we can indicate if there is right-sided involvement. Because if we see that there is indication of right-sided involvement, then we certainly do not want to give nitrates. Nitrates are contraindicated in right ventricular MI. Now, it is important to note that inferior MI is not an absolute contraindication for nitrates. You must confirm that there is right-sided involvement as well. So a quick and easy way to acquire the right-sided ECG, place the electrode in V4R, unsnap the lead V4 and snap it onto the new electrode, then press acquire. Now you want to make sure that you do mark this, all right? And if you see ST segment greater than 1 millimeter, it may indicate a right ventricular MI, and that's going to be enough information there for you to determine, hey, I probably want to withhold nitrates. Now, right-sided MI does not respond well to nitro or any other nitrates. Certainly will cause some hypotension issues, and in turn will cause some cardiac output issues. So what you notice here, you see the area of infarction is down here on the inferior side, and so obviously you do have right ventricular involvement as well. Leads 2, 3, and AVF. Now what's unique about this is that these are limb leads, so you can actually identify inferior infarct by your normal leads, but you do have to see your contiguous leads. So you want to double check and see if you've got the reciprocal ST changes in leads 1 and AVL. Now, what you notice here is that this is past the point of ST segment elevation to the point to where Q waves have now developed in leads 2, 3, and AVF. Now, how, again, do I notice that it's a Q wave? Because it is a downward, it is the first negatively deflected or downward wave past the P wave. So significant Q waves and T wave inversions in leads 2, 3, and AVF with lateral damage changes also may be seen in V5 and V6 in this situation here. So here's another example. So here we still have ST elevation, but we have the beginnings of Q wave formation. And I notice that I should be reciprocal ST depression in leads 1 and AVL. So inferior wall MI 2-3 AVF with reciprocal in leads 1 and AVL. Now we'll move on to lateral wall, and in this situation you'll notice ST elevation in V5, V6. 1 in AVL if it's high lateral involvement. High lateral wall MI can have reciprocal changes in 2-3 and AVF. Now again, your reciprocal changes cannot cross planes, and so frontal plane leads versus horizontal plane leads are only going to have reciprocal changes with like leads. So frontal with frontal and horizontal with horizontal. You will typically not see, or you won't be able to see reciprocal changes across the planes. So with a lateral MI here, if you have high lateral wall involvement, which would indicate here, you'd probably see reciprocal changes here, at least in 3 and AVF, maybe 2 as well. So lateral infarcts can occur by themselves or in combination with anterior, anteroseptal, inferior right ventricular, or posterior AMI. Always look at all regions of the ECG to obtain additional leads to be sure. So again, your high lateral is 1 in AVL. Your low lateral is V5, V6. If you have high lateral involvement, then you may see reciprocal changes in 2, 3, and AVF. So an inferolateral is going to actually be the inferior leads and your lateral leads, which combined together will see ST elevation in these areas here. So again, you've just taken your inferior leads and your lateral leads and combined them together, and you're having active involvement in all of these areas. Anterior MI, this is going to be leads 3 and or V3 and V4. It's rare to have an anterior MI alone. Typically, you will have other things involved, such as your septal area. So in this case, this is showing anterior wall. Not really any reciprocals here that you could notice. On this next slide, you will see that we have Q wave development significant Q wave development and T wave inversions in leads 1, V2. So lead 1, V2, V3, and V4. Now here you have R waves there, so you do have wide QRS, but these are going to be very wide here. Now this is later, so for anterior, I would also want to see ST elevation in V3 and V4. So these are just different examples that you may have with your anterior involvement. So this anteroseptal reciprocal changes, again, the limb leads are in a different plane. Technically, the reciprocal will be in the R leads. If you see ST changes in other leads with anteroseptal, then you probably want to consider that there are other areas involved. So, for example, if you do see leads 2, 3, and AVF ST changes, then most likely that's going to indicate that there is inferior involvement as well. So your anteroseptal leads here, you'll see changes here in V2, V1, V3, and V4. So an anteroseptal lateral extension, this is a very significant MI caused by obstruction of the proximal left main or the proximal left anterior descending coronary artery. Estimation V1 through V6 leads 1 and AVL. So this is going to essentially involve pretty much the whole left ventricle. This is also known as an extensive anterior, and because of the leads 1 and AVL involvement, you may see reciprocal changes in 2, 3, and AVF. So again, this is just showing the 1 and AVL. So these reciprocal changes in 2, 3, and AVF, they are only due to 1 and AVL being involved. So then you have V1, V2, V3, V4, V5, and V6. Notice the significant ST elevation in V4, V5, and V6. And then you're starting to see some Q wave development in V3 and V4 as well. So again, this is a very significant MI. Anterolateral changes in 1 AVL, V3 through V6. Again, because you have 1 in AVL, you'll have reciprocal changes in 2, 3, and AVF. Now, of significant note here, you would have loss of R wave progression. That is one thing that you do want to see in a normal 12 lead is R wave progression as the axis moves, or as the leads pick up the axis as it comes towards it. This could indicate occlusion of the left circumflex or marginal branch of the left circumflex, or the diagonal branch of the left anterior descending artery. Again, all involving left-sided coronary arteries, which are very significant to the blood supply. So posterior wall MI. Now this is unique in the fact that most agencies, most pre-hospital 12 leads are only going to be doing a 12 lead. So in this case, what you would want to see if you were trying to diagnose a posterior MI is going to be changes in V1 and V2, ST depression in the septal leads V1 and V2 because of the plane in which you're looking. So your posterior leads would be V7, V8, V9. And so these are going to be on the opposite side. So if you see ST depression in your septal leads with chest pain reported indications of MI, then you certainly would want to consider posterior MI here. And so again, this is going to be occlusion of some of your arteries that run across the back part of the heart. So since no ECG leads reflects posterior electrical forces, changes are reciprocal in those anterior leads. V1 shows unusually large R wave, which is a reciprocal of the posterior Q wave in this particular one, and upright T wave, which is going to be the reciprocal of the posterior T wave inversion. Now, let's say that we saw inferior MI and we decided to do a V4. Then we notice that we have right ventricular MI. Well, of course, we do make the clinical decision that we do not want to give nitrates. Now, what you can do is move the other leads over, but diagnostically, at least for our treatment of chest pain, this is a quick diagnostic in the field to move V4R over, but we don't want to give nitrates. Our treatment is essentially going to be the same minus the nitrates, minus the vasoactive medications. Another thing that you can notice is ST elevation greater in lead 3 than 2, even before you've moved your lead over. 97% of right ventricular MIs are associated with inferior MI. So that's why it is a very fine line right there for you to make sure that you are detecting right ventricular MI. Only 3% of the time, a left circumflex artery can be the cause of the right ventricular MI. So these images are just reaffirming again, just showing you what arteries are involved. So if you notice here, your lateral wall MI, 1 AVL, V5, and V6. So again, just as a reminder, lead 1 in AVL, that's going to be your high lateral. V5 and V6, that's low lateral. So in this case, you've got your circ and your one of your diagonal arteries here, which are bifurcating off of the left anterior descending. So it all depends on where the occlusion is. If it's very high, then it's going to occlude all of these vessels. In this case, the occlusion went down to the circumflex and then the diagonal artery right here. But again, if it does involve high lateral and low lateral, then you're going to see leads 1, AVL, V5, and V6. If you have elevation and leads 1 in AVL, then you can expect for reciprocal changes in 2, 3, and AVF. With your inferior MI, 2, 3, and AVF, in some individuals, the circumflex artery supplies the inferior wall through the posterior descending artery, which is the left dominant system. Blockage of the posterior descending artery will result in an inferior infarction. However, a proximal occlusion of the circumflex may result in infarction in the lateral and posterior walls. Your coronary anatomy shows a dominant left circumflex artery, which is here. Occlusion at point A results in an inferior infarction. So if you notice, this is the dominal circumflex as it circles around, so your blockage would be there, so there would not be blood flow down to the bottom or the inferior area. An occlusion at point B may result in infarction in the lateral and posterior walls. So your septal leads, V1 and V2, leads V1 and V2 face the septal area of the left ventricle. The septum, which contains a bundle of His and bundle branches, is normally supplied by the left anterior descending artery. If the site of infarction is limited to the septum, ECG changes are seen in V1 and V2. A blockage in this area may result in both right bundle branch block, left bundle branch block, which is more common, second degree AV block type 2, and third degree AV block. If the entire anterior wall is involved, you'll see ECG changes in V1, V2, V3, and V4. So anterior wall is going to be V3 and V4. Because the left anterior descending artery supplies about 40% of the heart's blood, and a critical section of the left ventricle, blockage of this vessel can lead to complications, including heart failure and cardiogenic shock. Sympathetic hyperactivity is common with resulting sinus tach and/or hypertension. An anterior wall MI may cause other dysrhythmias, including premature ventricular complexes, a flood, fibrillation. Because the bundle branches travel through this area, bundle branch blocks may also result from injury to this area. So again, and this is a difficult concept for someone that is just getting into learning 12 leads. It is a difficult concept to grasp here, but this posterior wall MI, if you're just doing a 12 lead, you're not going to see posterior wall leads, which are V7, V8, V9. You're not going to see ST elevation in those, but due to the fact that V1, V2, and possibly V3 are reciprocal, you will see ST depression if you've got posterior wall MI. 15 to 21% of infarctions are posterior wall MIs, usually in conjunction with an inferior or lateral infarction. The posterior wall of the left ventricle is supplied by the left circumflex coronary artery in most patients. However, in some patients, it's supplied by the right coronary artery. So repetition is really how you learn things and remember things. So again, this is just a reminder of what you will see. Inferior wall, you'll see issues in 2, 3, and AVF. Septal wall is V1 and V2. Anterior, V3 to V4. High lateral is going to be 1 in AVL. Low lateral is V5 to V6. And then if you are having to, if you see an inferior wall MI, you want to get a right ventricular look, you want to do a V4R. Now, again, your posterior 7, 8, 9 not available on the standard 12 lead. You'll have to get a 15 lead, but you may see reciprocal changes in V1 through V3. So as far as treatment goes, treatment has not changed. If you're listening to this as a paramedic student, treatment has not changed from when you learn how to do it as an advanced EMT or even as a EMT. One of the only main differences here is that you are going to also give analgesia as well. Always, always, always give aspirin. Chest pain. All pain is cardiac chest pain unless otherwise ruled out. You want to give aspirin. Aspirin has the antiplatelet. It keeps the platelets from aggregating, so it is not a clot buster, but it is going to help keep the clot from getting bigger. Consider nitrates. Now, again, as a reminder, if you have right ventricular wall involvement, you do not give nitrate. If you do give nitrates, you should have your IV before administration. everyone reacts to medications differently, especially if they're on the borderline of being hypotensive as it is. Now, we give nitrates because of the vasodilation, which is going to improve blood flow to the areas of infarction. Your dosage here is 0.4 milligrams if the systolic blood pressure is greater than 90, and you may repeat twice every 5 minutes for up to a total of 3 dosages. Consider oxygen. Even the American Heart Association says this keyword, consider, because there have been studies to see that have shown that oxygen, being a vasoconstrictive drug, being a vasoactive drug, can actually cause some issues. So we certainly don't want to clamp the coronary arteries down even more. So the old misnomer, or the old anecdotal treatment of high flow oxygen to chest pain is not only inappropriate, but it could even borderline be negligent. Only give oxygen low flow delivery of less than 94% SpO2. We don't want to overflow with oxygen. There's much more important things that we need to be doing than putting high flow oxygen on a patient. Again, it's not an issue with the fact of oxygen being in the blood. It's an issue with the fact of the oxygen that's in the blood being unable to get to the area that has been occluded. And then analgesia. Morphine is actually falling out of favor now as far as treatment of ACS. There are some much better drugs, such as fentanyl and even ketamine. Ketamine has become a favorite for many reasons. One of the reasons is that you don't have to give high dosages of ketamine for it to have its analgesia effects. Your dosage with ketamine is 0.2 milligrams per kilogram, so IV. State of Alabama says 25 milligram max. Or you can give ketamine IM, which would be 0.5 milligrams per kilogram with a 50 milligram max. Fentanyl is 1 mic per kg, slow IV push, IM or intranasal with a 50 mic max. And then morphine, 4 milligram IV initial dose, titrate by 2 milligrams every 3 to 5 minutes for a max of 10. Now, if the patient is refractory to these analgesia dosages, you certainly want to get in touch with med control to see if they want to do anything else. But as always, follow your local protocols, your local standards of treatment, and want to make sure that you are in compliance with that. It's very important as a paramedic for you to understand that STEMI treatment involves rapid reperfusion, which is going to involve rapid identification. So you've got 3 categories here with chest pain. You've got STEMI, you've got non-STEMI, and you've got a normal or a non-diagnostic. Your non-STEMI, no noticeable ST elevation, but you could have Q-wave development, or you could have T-wave inversion. Your STEMI, your ST elevation in 2 or more contiguous leads, or new or suspected left bundle branch block. Left bundle branch block is going to be considered MI until proven otherwise. It's very important to remember that a normal ECG does not rule out ischemia, injury, or infarction. We treat all chest pain as cardiac chest pain until proven otherwise. Patients with ST elevation are candidates for percutaneous coronary intervention. So we certainly want to recognize this, and we want to make sure that we are getting this information to the receiving hospital. The standard of care is going to be to do a 12-lead ECG. The standard of care is going to be to diagnose early. Yes, EMS has to diagnose based off of what we're able to find. Now, of course, we are going to allow the official diagnosis to be left to the cardiologist, but in order to treat your patient, you're going to have to diagnose. Another standard of care should be to fill out the thrombolytic checklist. If you have a STEMI, fill out the thrombolytic checklist, because the patient may not go to the cath lab, but they may still be a candidate for thrombolytic therapy. There is many exclusion criteria, which there's potential or absolute contraindications. Then you do have potential or relative contraindications, and that's going to be up to the physician to determine whether or not they want to give the thrombolytics. But our role in this is going to be to fill this out and have this available whenever we contact the receiving hospital or the STEMI system if your agency or your region, your area has it. This is acute coronary syndrome's algorithm from the 2015 update from American Heart Association. I just want to quickly go through the EMS section here. So if you've got symptoms suggestive of ischemia or infarction, your EMS assessment and care should be monitor, support ABCs, and be prepared to provide CPR and defibrillation at any time. It is not above the realm of possibility that if a patient is having an active MI, that they will not go into cardiac arrest. Minister aspirin. Absolutely. Your first drug is going to be aspirin. And consider oxygen if their SpO2 is less than 94%. Nitroglycerin if no left or right ventricular involvement, and morphine if needed, or whatever other analgesia is considered within your region or your area. 12 lead. 12 lead should be transmitted. You need an initial 12 lead. You need an initial set of baseline vital signs and that initial 12 lead. It is very important. The notified hospital should mobilize the hospital resources to respond to the STEMI because this patient does not need to sit in the ER. This patient needs to go to the cath lab. Time is muscle. Time is muscle. And then if considering pre-hospital or fibrinolytic therapy, use the fibrinolytic checklist. And then there are going to be more treatments in hospital, such as different labs, such as the troponins and different treatments there. But we're not going to get into that during this lecture. So in summary, the patients may not benefit from emergency PCI, but that is not going to be for us to determine. They do benefit from ischemia treatment that may prevent an infarction. Remember, your goal is to prevent the extension of the infarction. But the only way to properly do that is to be able to identify the area of infarction, to treat chest pain as cardiac chest pain until proven otherwise, and do the treatments that are part of the standard of care. So again, thank you for watching this lecture. You can always contact me, Nick Ray, at suscc.edu.